All right, here we are. We are at the next generation of a nursing care model, Module 9. And in Module 9, what I really wanted to focus on was kind of where are we going from here? We've had the opportunity through the course and the various other modules to take a look at, a managed care contract. We looked at how the healthcare dollar works. We looked at the revenue process and the roller coaster ride and how things operate and work in your practice. And then we kind of looked at how do we know you're doing well with performance indicators and what would a practice revenue projections look like and all of those fun things. And then we started looking at it and saying, well, wait a second. The world around us is constantly changing. So this module kind of says, what do we have to do to kind of look back and say, how do we adapt that type of infrastructure that we kind of looked at in the first 8 modules to then look at where we're going. So that's kind of what I basically want to do here is look at what's incentive-based payment, what's it look like in the future modeling, and then how do we adapt, and what kind of programs can we have that make it look like that. So when I started looking at your merit-based incentive payments and where we're going as a market, you look at encounter-based care. Today, it really is, or I should say yesterday, it really is the start at 8 o'clock in the morning, who can run to 5 and see the most patients wins. And that's not a nursing model to begin with. And we've always kind of disputed that and said, that's not the same way. I want to see 2 patients in an hour, not 9. And the physician model tends to drive that volume and quantity type based approach. And we've always wanted to say, no, we can make the same amount of money by doing less. Well, now as we start moving into management-based care, we're going to value and quality over volume and quantity. We're going from where fee-for-service payment is, where I get paid every time I see the patient. That's not necessarily the case anymore. It's moving to value-based payment where, if I think just a transitional care, you don't get paid, you're managing a patient after a post-discharge for 30 days. If they get readmitted, you don't get paid. If they don't get readmitted, then you get paid. Well, that is not a fee-for-service model. That is very much a value or an outcome-based model where you've got some risk and stake in the game. We're also moving from where patients, you kind of did blood pressures and said, hey, you have high blood pressure, and, if something comes up, call me back and we'll take a look at it. Well, that's encounter-based. This patient, silo patient care is, come back when you need me. And we're not doing that. We're saying stay connected to the patient. Now we've got to manage that patient. So your blood pressure is high. I put you on some meds. I'm going to be reaching out to you. I need to make sure your blood pressure is under control. And actually what's happening is that's tied to the bottom line because there's a demand for better outcomes, lower costs, and improved efficiency. And the way to do it is to do it through money. So looking at the future, our value-based payment modeling is kind of the foundation of, we've got to embrace technology. We have to do data analytics. We are looking to go from transaction-based activities to truly transformation in patient care, where we have lower cost, better quality, where it's truly a cultural change in care management. I work with a practice that has a physician who's an older school physician, and he is a transaction-based type provider, and we're pushing we're going to monitor quality indicators. We're going to get care coordinators, and I'm going to pull social work in, and we're going to really manage our diabetic patients. And I'm showing them all how we have to do that because of the demand or the reimbursements now getting tied to it. And I feel like I'm pulling some of these physician providers along where the nurse practitioners are like, hallelujah, we finally get paid for what we've been trying to do. So I'm very excited about where market is going in that regard and how it's then going to be supporting us. Is it here? Oh my God, it is here. 2018, 90% of the Medicare payments made to healthcare providers were tied to quality. Actually, your Medicare shared savings programs have actually been around since about 2012, so that's not stunning or surprising. Now, when you look at commercial carriers, you say, well, they've always kind of been slower to the game and behind the boat. Well, not on this initiative, I can tell you that. And in fact, by 2020, 75% of commercial plans will have value-based programs in place and tie outcomes and quality to reimbursement. And we see it today. And that's what our next group of slides are going to show you is how are they doing that? Like, what's it really mean to me? I don't get that. Like, I get that quality is in pay, but how does that happen at the claim level? Because remember, we send claims out and we get claims back, and how do I get more money? So that's what we're going to talk about. um, timeline. This is just to kind of show you that 2015 is kind of when this all started happening, and we're getting through the years. We're obviously the 18, 19, 20 range here coming up where adjustments are going to happen. And so just wanted to share with you a timeline there of how this is evolving through the years. All right, so let's look at this one. Here is a 2019 professional provider quality-based reimbursement program. This is from Blue Cross Blue Shield of Kansas, and they now have a program that said, "Hey, Ken, you have a medical practice, and Dr. Ken, if you have more than 85% of your patients who are between the ages of 3 months and 18 years of age who are diagnosed with an upper respiratory infection and you didn't dispense an antibiotic prescription, good for you. We're going to pay you 1% increase in reimbursement." Now, the HEDIS measure down below kind of shows you that Blue Cross Blue Shield of Kansas, that top measure, is just drawing off of the HEDIS measure at the bottom that says, the percent of patients 3 to 18 years of age are diagnosed with upper respiratory were not dispensed with an antibiotic on or 3 days after the episode. So this is kind of indicators now that if I do this, I get a 1% increase. Well, let's go to the next one. In my adults with acute bronchitis, the percentage of adults 18 to 64 years of age that are diagnosed with acute bronchitis who are not dispensed an antibiotic prescription, if I have more than 30%, that's not a lot, but if I have more than 30% compliance with this, where that didn't occur, because maybe it is appropriate in some cases, but if I meet this criteria, I get another 1%. So practice A is sitting over here going, I don't care about any of this stuff. Just let me see patients. When they cock in the door, I'm going to take care of them. When they walk out the door, they'll come back to me when they need me. Okay, yeah, that's not where we live anymore, but I'm glad that that's what you want to do. So you're practice A and you stay over here. Meanwhile, practice B, I'm over here and I've already got 2% higher reimbursement. So when my little claim for service comes through with my office visit, I'm already at a 2% higher reimbursement than practice A who's not doing these things. But let's continue. Let's talk about diabetes. I have a diabetic population. Okay, so usually we look at the percent of patients that are diabetic between ages of 18 and 75 years of age as the HEDIS measure. And we want to try to control and say, hey, look, if you're over 9.0, that's not a good thing. And we want to always try to bring down the number of patients in our practice that are over 9.0. And we deploy programs and methodology and monitoring and things we need to do to get paid. Well, gosh, in this case, all they want to do is say, good God, just test the people. Just test during the measurement period. If they're between 18 and 75 years of age with diabetes, type 1 or 2, did you do a hemoglobin A1C? If you did, on at least 90% of everybody who are between ages 18 and 75 in your practice, and they had an A1 hemoglobin test, I don't care what the results are, but they just at least had the test, you get 0.5% reimbursement. So now I'm at 1.5%. So you can start seeing that my numbers can start adding up pretty quick here as I start working through the process of, well, which patient bases do I have? What's going on with them? I have these diabetic patients. Am I managing these diabetic patients? And you'll see I've kind of prepared or crafted concepts around how we as nurse practitioners or the nurse practitioner profession can then put programs together to make money and have the practices that we work for benefit now potentially right here up to 2.5. But let's not stop there. Low back pain. If I can manage and meet this criteria on low back pain, that's another 5. I'm now 3% ahead. So you can see how at the very lowest level of common denominator, I'm now at a higher reimbursement by 3% over the practice A who's not playing the game in reimbursement. I can get to 10, 24% by carrier in reimbursement. That's going to separate those who are playing and those who aren't playing. So these are, and it's a good practice in many of these cases. So preventive, we have adolescent well care. I know not all of us are adolescents, some are adult, but let's look at this. Percentage of members who are 12 to 21 years of age who had at least one well care visit. I think we can make that happen. That's another 0.5 reimbursement. So when I get paid $100 for a visit, or say a well exam, I now would receive, if I go through my semi-annual qualifying period audit, I can generate then not $100, but $100 plus 4% more just by quality-based reimbursement. There's no penalties in this. The penalty is you don't get anything. The penalty is you might get kicked out of the network if you aren't a high-quality provider, which United Healthcare has done to 10 to 15% of its providers in the Medicare Advantage program. So these are the types of indicators that can generate your money at the time, right there at your clinic. You'll see the check come through the mail higher. BMI, this isn't an indicator that gets paid in this program, but it is a HEDIS indicator. This show, that BMI could be another one. Now, what is nice is you look at care planning, so that the percent of patients over 65 years or old who have an advanced care plan or documentation of a decision maker in their record. Well, that's not an indicator that like Blue Cross Blue Shield is paying for. That's not an indicator that United Healthcare or Aetna has kind of put in their QB RP programs. But if you talk to patients about advanced care planning over the age of 65, you bill a $99497, you're getting $73.58. Chances are you already are doing this, and you don't have to execute documents at this either. This is care planning, counseling, talking to the patient, making them aware of it. And if you had 2,000 encounters and say 10% of them you talk to about advanced care planning, that's like $14,716. Folks, that's real money. And you get credit as a CMS or as a NQF, National Quality Forum, qualifier indicator through NCQA, excuse me. So there's real money at this. So there's no reason why you shouldn't be incorporating programs like this into your revenue streams to support your business. Finally, as we look at preventive care, here's another place you can grab another 0.5 or 2% is on colorectal screening and cervical cancer. Now, see, here's the thing that we have to keep in mind about this stuff. This is not encounter-based healthcare, because who are your women 21 to 64 years of age in your practice, and how are you making sure they had a cervical cancer screening and your EMR has that captured properly so you get that increase? How are you making sure you know who your adults 50 to 75 years of age are, and making sure that 60% or more of them in your database of patients that are on your roster had a colorectal cancer screening to then get those to combined 1% reimbursement? It's about data analytics. You need to understand and know your patient base. That's why when we were up here, oops, wrong way. That's why when we were up here, I had said on this slide, it's healthcare data analytics. You need to know your patient base. And the reason why is I need to know who are the 3-month to 18-year-olds to make sure that had upper respiratory infection. Where are they? Who are they? How many of them did I have? That's 1%. Then here's another 1%. And then here's another 0.5% and another 0.5. Now I'm at 3% reimbursements. Here's another 0.5. Here's another 0.55. That's another 1.5. I'm already up to 5% increase in reimbursement just by doing this, just on Blue Cross Blue Shield's quality-based reimbursement program. Aetna has one. United has one. All the carriers have one. Here's one that isn't really kind of a quality-based reimbursement, but is part of their care improvement, is Blue Cross Blue Shield of Kansas is going to pay you 3% more. So now I'm up to 5, 6, 7, 8% over practice A to practice B. Just get off the phone. If you use the electronic tools given to you to run your 270, 271, remember in Module 6, we talked about real-time eligibility occurring during virtual registration. That's your ANSI 270, 271 files where you log in and verify eligibility and benefits electronically. The 276, 277 transactions, those are your claim status inquiries to know where are you, what's your status of your claim. That, again, is part of the revenue process that we discussed back in the third-party recovery component of Module 6. So if you do everything online, checking claims, checking eligibility, working appeals, and you don't pick up the phone and call them, if you do that 96% of the time, that's a 3% increase in reimbursement by just staying off the phone. When you stay off the phone, their costs go down. They're sharing the cost savings with your practice for not calling them. Now, if you're going to sit there and say, well, I want to pick up the phone and I want to call and I want to talk to someone, well, then you go right ahead and do it, because you're like practice A and you're not going to make the extra 3% money. But if you figure out, modernize your practice, get with the program, get online and use the tools, Then you get another 3%. So all of a sudden, just in this handful of sample slides, I'm up to an 8% differential. Practice A doesn't want to play, that's fine. You just keep going broke. So that is kind of the incentive piece. Well, if you think about it, what is going on? We now have to track who our patients are, what their ages are, who's had physicals, who hasn't had physicals, adolescent immunizations. Did all the kids by the age of 13 have all their injections done? Is my A1C people at a 9 or below? Am I getting my high blood pressures under control? And you want me to keep all my E&M documentations and do a complete history and physical and an exam and medical decision making and charting. Well, Patients Over Paperwork is the initiative, love the name, and the initiative is to focus on reducing the administrative burden while improving and doing the stuff we just talked about of care coordination and looking at health outcomes. Well, to do that, they had to loosen up some of the criteria on all of this coding stuff. So for established patients, there's no longer the requirement to re-record history and exam at every visit. They are now looking at and have said that the information previously documented, if it's there, is evidence and there's evidence that the practitioner reviewed it. You don't have to re-document history and exam at every visit. Because remember how we've programmed all of our EMRs to pull in the history and then you can mark obtained or reviewed because you had to have the history in that progress note? Well, they're kind of saying, yeah, let's set that aside because that's a little extra. We're also saying that if I have a registered nurse and they're entering all the chief complaints in the system, and the nurse took the history, that I, as a nurse practitioner or physician, do not have to re-enter that stuff because you have to document as if you did it, but rather just the provider needs to indicate they did review and verify. So they're trying to loosen up some of the documentation standards required to chart evaluation and management services. In the same area, they are changing the payment structures. You no longer need to worry about level 3, 4, and 5 in 2021. You do next year and the year after, but in 2021, they're going to be getting rid of all the different levels of service with Medicare. So your documentation in your chart only needs to be at that of what you would get for a level 2. There's no reason to go through and worry about the medical decisionation, the in-depthness of the exam, because by 2021, there's 2 levels. There's basically a 1 and a 2 being collapsed down. Now, you can look at that and say, well, wait a second. I usually bill really high, like a 4 and 5, because of the complexity of my patient and blah, 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 blah. That's okay because there are modifiers or additional payment codes that if you have a prolonged visit with a patient, you can get $67 added onto this. $14 can be added on if it's a non-procedural based care for the complexity of that patient. And then you get a $5 add-on to recognize additional resources. So I'm going to have these little add-ons that I can add a 67, 14, and 5 onto my 135 or my 93. Now, what is interesting, if you look at the way we code as a profession of nurse practitioners, on my established patients, a level 3 and a level 4, we equally up here in the top left grid, 2 and 3 on 5.9 million visits where the nurse practitioner name appeared on the claim for $359 million in charges, level 3 and 4 were consistently right at the same place. Family medicine, doctors, the 4 kind of tapered down. But for our professions, 3 and 4 stayed the same. On new patients, where the physicians stayed more at a level 3, tapering quickly off at 4 and 5 on new patients, we're actually higher at a level 4 under the guidelines of the 95, 97 documentation standards for new patients, which doesn't surprise me at all. So when we look at what the impact is in 2021, I'm at a level 3 or 4 over here on the left-hand side, the 74 and 109. So 93 is about right. But if I get all my add-on codes right here, that's really cool. But on my proposed here, I'm going from 167 to 135 because we as nurse practitioners bill more level 4 new patients. So you can say, well, that's a hit. But again, you've got to be conscious of the additional payment codes that are coming up. So all of this is all in an effort to say our focus is on care coordination, health outcomes, and the patient's ability to make decisions on their own about care and get them to a better place. And these are documentation steps that are being saved so that we have the opportunity to spend our time and refocus our energy to get there. All right, so I'm going to stop the recording here because we're now getting ready to go into something more exciting, which is talking about how we can program and put thought processes together so that we can truly reflect an impact on those 5-8% differentials. Because think about it, doctors today, they're so busy, they're so transaction based, they can't stop and restructure their entire mindset to go ahead and address quality based incentives like this. So I'm going to talk a little bit about how the nurse practitioner can be a collaborative group practice in a practice model to help us out. So we'll get ready to go on to the next video and we will do that.